All right, today we have Kurt doing a talk on marijuana and pregnancy. And I think everyone knows who we are. Dr. Kurt Devine and me, I'm Erin. Good to see everybody.
The SOAR Echo schedule change. After 6.5 years, we are going to switch to every other week. So we'll be doing this every other week from now on. And actually, the weeks that we are off, the Native American, the NAC Echo will be taking place on those days. So they're typically on the same day as us, but we're cutting back to every other week. So I hope nobody cries, but I don't know. I kind of feel like it'll be a little bit of a break after so long of doing this. So, but lots of good talks coming up. Lots of fun things. Did July 10th fill up with that group that you were working with? Yep. Who's that?
That is Zero Suicide.
So we have the Zero Suicide people talking July 10th, the prep talk after that, and so on. So lots of good talks coming up. Remember, Erin, as she pointed out last week, the other Echo series are noted at the bottom in case you want to learn more.
There's free CME offered with these sessions. Just make sure you fill out what Katie sends following the sessions. And we love to see everyone's faces. If you're willing to turn your camera on and interact, it makes it fun.
Way more fun. And remember, if you need a little help, feel free to give us a ring. Easy to get hold of. Erin's stuff is right there, phone and email. And then worst case, try me during the days. It's kind of hard to get hold of me unless sometimes I get calls from Erin. So feel free to reach out with something that we could help you with anytime.
And then we do have the core website available. Any policy, protocol, workflow items are spelled out in this website. So it's a nice resource so you don't have to reinvent the wheel.
All right. So today, I guess I'm up. And what we're going to do is we're going to talk a little bit about some of these different things associated with marijuana. Now, a few months back, I gave a talk on considerations of marijuana because so often, if we all recall, everybody thinks this is a medication now. The marijuana is safe and it's a medication, but there are certainly a lot of problems with it. And marijuana and pregnancy is kind of kind of one of those things that we don't think about often. In my clinic, I most definitely see pregnant women who have been using marijuana, and we have conversations, or people who are considering pregnancy, and how that's going to actually affect the pregnancy is important to kind of discuss. Next slide. And we're going to talk a little bit, probably a month or two down the road, I have another talk about newborn and later childhood outcomes, kind of a review of that, because to be honest with you, that's pretty frightening as what happens to the brains of babies as they get older, and it's really something that I find quite interesting. Next slide. Today we're going to talk about, again, reasons pregnant patients use marijuana. We're going to talk a little bit about why it's hard to study, which again, some of the legal changes at a federal level may make it easier for us to study marijuana. We're going to talk a little bit about marijuana and the effects on stillbirth and miscarriage. And actually, if we have time, I have a couple things at the end, including a little discussion on the timing of when people use marijuana and how that may affect the pregnancy, and also how well does treatment work and what kind of treatments work for people with cannabis use disorder who are pregnant. I'll probably add that on depending on how the time is. I kind of got it ready just in case. Next slide. So one of the papers that I really spent a lot of time on, and again, there's not a ton of information on pregnancy and any substance use really, and marijuana is no exception. There was a review done, and this review was done in 2010. And if we think about it, even when they did that review back then, marijuana was still a different animal. It was not quite what we're seeing now. And the different ways we see THC show up, whether it's edibles and dabs and all kinds of things, it's a little bit different. But it is the most commonly used dependent substance in pregnancy. And again, we'll talk about why that is. We'll talk a little bit about some of the developmental disruptions that we see, and again, some of the growth issues and why that's occurring. And again, the neurodevelopmental consequences is going to be a talk that I do at a later time, which again, to me is pretty concerning. Some of the studies we're seeing on THC and kids as they grow up. One of the problems that Thompson noticed was really when he looked back and he did this review, those low THC levels in the 80s and 70s and 90s, a lot of these studies really wouldn't apply now with THC levels that are 3 and 4 times higher. Often these studies were observational. A lot of them were retrospective, really depending on the memory of patients to say, oh, I was using marijuana. I used it in these parts of my pregnancy, and then looking at how their pregnancy went. And so a lot of that was difficult to compile. And obviously, polysubstance use always complicates everything because it's always really what caused what and how much of the issues that happened were actually brought about by the THC. And I think that's always going to be a difficult thing to ascertain whenever we have people using multiple substances. Next slide. So when we look at marijuana and pregnancy, if you look, 50% of people who use cannabis and become pregnant are actually, continue to use. And really, this is about a third of our pregnancies are impacted by marijuana. I think if you were doing OB in this day and age, and you knew that 1 in 3 of your patients at some point in their pregnancy is smoking marijuana, I think that would be an important thing for you to have a conversation with the patients. And sometimes they don't self-report. I think a lot of this, especially since it is a medication now, so you can get medicinal THC, it's that perceived safety, right? It's legal. It must not be hard on the baby. And so patients continue to smoke. They'll stop drinking often because it's pretty well known that fetal alcohol syndrome is a big concern. But we think about also, why would somebody want to use this in their first trimester, which is relatively common? Sometimes they use it because they don't know they're pregnant, but other times they use it because it helps their nausea. And so it's important to have these conversations. And I think that often when you look at their intakes, if it says they're not using marijuana, that really should be confirmed. And I think really when I do the talk down the road on some of the effects on infants and children, I do think it's very important that patients know those potential outcomes. Next slide. So what's the big issue with marijuana? Well, one of the biggest issues is it zips across that placenta really fast, right? The placenta is no barrier for THC. And if you think about what the fetal brain is made out of, obviously there's a lot of fat there. And interestingly, the placenta and the fetal brain have cannabinoid receptors. And so you're going to get the same effects on the baby and the baby's brain that we're seeing with effects to mom. And so really no difference. And in fact, a lot of the studies have shown that the levels of THC in babies pretty much mirror what the mom's is, which I think is pretty shocking when you think that they're getting exactly the same level. And again, there's a lot of studies that support some degree of developmental disruption. We're not going to talk so much about the development, but we're going to spend some time talking about some of the other things, including growth and different things that have been studied in people who are using. Next slide. I think one of the interesting things about cannabis that Thompson really thought was interesting in his paper was that, ironically, hops, which we use to make beer, is actually in the same family as cannabis. It's a similar type of plant, and I find that really pretty interesting that there is a relationship there. But marijuana really has an extensive medical history, and again, now in our day and time, again, there's medicinal marijuana, and the list of reasons that you can get medical marijuana is quite long. And again, poorly studied. But even back in the 900 BC, they were using it in India. Egyptians way back then were actually using marijuana as vaginal suppositories. So they thought of it as a medication for certain types of things. The Europeans knew that it had a mild analgesic effect, but but also some of these other things came to light, the relaxation from it, some psychopathic effects. They had all been well described quite a long time ago. So again, marijuana is nothing new. I think the studies on it are what we really need as to whether or not there's more risk than benefit for some of these benefits we get. Next slide. Now, I'm not going to spend a lot of time on this. Everybody, we've talked about this a lot on the echo about the cannabinoid system, the endocannabinoid system, and we know that we have the endocannabinoids naturally. Remembering that there are actually enzymes that regulate the production and destruction of cannabinoids as well, and those may vary genetically between people. And so the effects also can be different from person to person. Next slide. So we're going to talk about methods of use for a couple of reasons. And the biggest one really is that when we look back at the studies, one of the things that you notice in all the studies that have been done, even in non-pregnant studies, one of the issues is often is that they will find out that a patient will self-report use, but very frequently they're not self-reporting how they use it. And that is very obviously changes a lot because there's a big difference between smoking it or vaping it and getting it into your lungs and into your system very quickly, as opposed to taking oral and having much of that destroyed in the first pass. And so the levels in the bloodstream, I'm sorry, this phone I can't control. But the studies don't really check on that. They don't really point out how is this patient using it and relate that to better or worse outcomes. The only thing that we know is, for the most part, it doesn't get into the bloodstream from the skin, but the absorption of these suppositories, oral absorption, all these other things can be vastly different. And again, it's the fastest ways they get into the system that's going to give us the highest levels of THC, which may very well, although it's not been proven, be more detrimental to the infant. Next slide. And what else complicates it? Well, trying to study cannabis is always complicated by the polysubstance use. I think if we look back at all the studies that have been done, and again, we're looking at a very small number, the sample sizes are typically very small. I think anytime we look at studies that talk about self-reporting, we've got that whole memory recall bias. And again, often in those studies, they're not telling us how the patient was actually using the substance. So really quantifying their exposure, whether it's the percentage of THC in their blood or the volume, it's basically, these are all unknowns. And so a lot of the studies are just going to say they used marijuana during their first trimester. It won't say how many times. It won't say how they were taking it or what the percent of the THC is. These are all the things down the road that we're going to have to hopefully work out or have some understanding of. Next slide. Some of the other things is that a lot of the studies were, again, they weren't really set up to show that the patient was using it continuously, or the patient was using it intermittently, or the patient even used it once or twice. And so there can be an enormous difference between patients in the study who basically are counted the same way as using marijuana during their pregnancy. It doesn't delineate heavy and light. One of the problems is that very frequently people smoke marijuana. They also smoke cigarettes, and that can be a real confounding issue. And again, sometimes people are crossing over. Well, they might be smoking, they might be using edibles, they might be using combinations of products. And some of these products can vary substantially in how much THC they have. I had a guy who had a product that he eventually had a psychotic break from, and he had been told by his nephew that he got it from that it was like 80 or 90% THC. And the next thing you know, he was handing out $100 bills down his street and to the pizza guy, right? He really had some difficulty and cleared, but he literally had no idea how strong that was. And so, again, these things can affect pregnancies probably in vastly different ways. Next slide. So what's the prevalence of use in pregnancy? Now, if we look at self-reports, where we're not actually checking a urine or checking a blood, it's somewhere in that range of 2 to 5% by the studies that have been done. If we look at some of the urban populations, especially some of the socially disadvantaged groups, you can get almost as high as 30% of this patient group using during pregnancy. And really 48 to 60% will continue to use during their pregnancy and basically use in every trimester, which, as we'll see down the line, probably is the biggest effect, especially when we look at some of the growth issues, which can be severely affected by that. Now, one of the interesting things is if you look at how many people are smoking marijuana during their pregnancy, the numbers have skyrocketed really from the early 2000s until 2014. This is way before COVID, which I think increased a lot of other misuse of drugs. Next slide. And it's actually pretty dramatic. If you look, and this was from the NSDUH studies that they do that they do very frequently, and some great data comes out of this. But you can see that from 2002 to 2014, it's nearly a doubling in smoking marijuana during the pregnancies. And interestingly, when we look at the group that is smoking the most, it's really in that 18 to 44 year age group, goes right up to the top. Next slide. Now, fortunately, we have Colorado doing basically as a way for us to all learn, because they're 20 years ahead of us. And so we get to watch and we get to see what's going on there and the problems that they're having. Now, I think we all wondered what was going to happen with legalization and pregnancy use. I think we were all wondering what was going to happen overall. I think that anybody that's looked at all those studies, seeing a lot of interesting things, that when they legalized it, the use of alcohol actually went up, the number of DUIs actually went up, crime went up, and all of those things that were really reportedly, they felt that this was really going to decrease things, that people would drink less. And in fact, they actually drink a little bit more as far as overall sales in Colorado. But if you look at Colorado, 11% of people were using cannabis before they conceived, right? And then once they get pregnant, about 6% are continuing that use. So roughly about half. And if we look at Colorado's data, really that younger age group from 20 to 24 is really smoking a lot more, 4 times more than people who are over the age of 35. And so this is certainly the age where I do think that there's a lot of perception that it is safe. They don't maybe have the information that somebody who's a little older has gotten over time. It's interesting because a lot of the studies show that people more often will stop drinking, but they will continue their marijuana, which one could argue which one is worse. Next slide. So who is smoking in Colorado when they're pregnant? Well, if you don't have a high school diploma, about 16% of those patients go on during their pregnancy to continuously use marijuana. So when we're looking at the patient in front of us who is somebody who did not finish high school and they are now pregnant, we have to assume that basically about 1 in 8 of them is going to be smoking marijuana. And remember, from a talk I gave, a few months ago, that if you get a teenager and they are smoking cigarettes, if they're smoking marijuana, they're more likely to also be smoking cigarettes than either one of those substances alone. So people tend to use both. And again, that sometimes confounds the data because people are actually taking both of those substances in, which probably is additive. If you look at patients who had a college degree in Colorado, less than 4% of those patients actually continued to use marijuana during their pregnancy. And very interestingly, race and ethnicity in these two groups did not make much difference for the statistics. They actually were very similar in the long term. Next slide. So why is it so prevalent in pregnancy? And again, we talked about this a little bit, perception that marijuana is relatively safe. And I think that's ironic because marijuana, causes perceptual difficulties. But it's actually the perception that it's okay, that it's safe. And I hear patients every day, and I'm sure many of you in your clinics, you'll talk to patients about it, and they think that it is helping them more than it's hurting them, almost routinely. It is very rare that I get somebody say, I know it's bad for me. I really need to stop. It's more me explaining what can go bad and explain to them some of the complications of it, and letting them then decide whether or not that's would be a reason for them to taper back a little bit. One of the big questions really is this use during pregnancy secondary to expanded legalization? I think that's certainly possible, but I also think it's very likely that because you can get it medicinally, that somehow they feel like doctors have said, hey, this is okay. Doctors are giving out prescriptions, it must be fine. And so to continue it during their pregnancy, and I know in our treatment, people, and one was just speaking earlier, how sees a lot of people smoking marijuana who are pregnant. Next slide. So when we do the testing, it's important for people to understand that the actual test we do is for carboxy THC. So that's really what we're looking for generally in the urine and the serum, right? And that's actually the thing that's actually stored in the fat and is actually the second metabolite of THC. When we do newborn testing, we can do it lots of different ways, just like we can in a human. We can do serum and urine, but frequently they're also testing the meconium as a way to tell if there's been exposure. And just as an aside, I can just tell you that by December, some of what we do as far as reporting and testing for substances is going to change a little bit. I'm actually on a task force about reporting and testing for some of the different substance use disorders in pregnancy, and there's a real push to change that, and instead engaging the patients and trying to make sure they get their prenatal care. So what we do with this information, I think, is also really important, and when we decide to do it is important. Next slide. The cannabis pharmacokinetics as far as a pregnant woman are interesting because, again, as I said at the start, THC rips across that placenta pretty quickly. There's really no barrier to it. And again, the blood levels in that baby are going to pretty much mirror what the maternal levels are. And so we would have to think that the heavier the smoking, the more likely that we're going to have higher levels in the infant, and how quickly they go up depending on how the patient is using it. Whether they're smoking it or taking it orally, where much of it is lost to first pass, can really make a difference for that baby long term. It's interesting because most of the metabolites cross the placental barrier. They maybe don't cross quite as easily, but they do get across as well but just a smaller share. Next slide. So the other thing is there's very limited data on some of these things. And it's interesting that most of the studies that have been done, particularly on how it gets to the baby and how much gets to the baby, were done in the 70s and 80s. And this is when the concentrations of marijuana were a lot closer to 4% to 5%. And now we're looking at triple digits, right? Or triple times that. And so we know that things must be different. But the question is, number one, are the things that we're seeing from the marijuana, are they causal, and are they dose dependent? And I think that that's got to be really the focus of some of the different research that gets going, is to understand, is there a level where things really get much worse? Next slide. So that's one of the things now. There really is an effort to really look very closely at the health effects of marijuana, especially in pregnancy, and understanding better the pharmacokinetics and pharmacodynamics of it, not only at different concentrations, but also, again, this dose-response relationship. Are there certain people, if they use edibles and they have much lower levels, are they going to typically have babies that don't have as much problems? And when we think about alcohol, we all know that alcohol causes fetal alcohol syndrome, but there are clearly many cases where patients have had very little alcohol and have a baby that's rather significantly affected. And then we have patients who drank much more who seem not to have had nearly the outcomes. And so it's not always dose dependent. And the question is marijuana going to be in that same category? Most of the studies that have been done on pharmacokinetics and pharmacodynamics and dose response have been done on non-pregnant subjects. They've been based on looking at the patients and some of the potential adverse reactions they may have. So in some of these recent studies, they have found that the levels in the fetuses can really vary significantly, and it really depends on the method of ingestion, not injection. We're not injecting it. I'll have to change that. but it really is the method of ingestion that tells us whether or not we're going to get those higher levels. Next slide. So one of the interesting things is, and we know this with both cannabis, with THC and CBD, they have an effect on the placenta's normal transport mechanisms, and that's not worked out why. But what we do know is that when people use cannabis, it apparently changes the normal transport mechanisms and sometimes makes it easier and sometimes makes it harder for things to get through the placenta. CBD actually in some studies has been shown to enhance the permeability of the placental barrier, so many things can get through there that normally wouldn't. I find this last thing where we talk about the placental blood flow dropping pretty interesting, because if you look at now some of the data that's come out in regards to the cardiac effects of cannabis, we know that there's vasoconstriction in the coronary arteries with cannabis use. And it's interesting that when we look at the placental blood flow, we actually see a drop in that as well, which obviously is going to have some effect on that baby long term if they are a frequent smoker. So we get that same effect of decreased blood flow, constriction in those blood vessels in the placenta. Next slide. So bioavailability, again, we talked about it a little bit, just in fact, because it does change the levels that are going to be in mom's blood, and then is obviously going to change the levels that are in baby's blood. And so again, that oral intake absorption is actually quite high, although often delayed. But that first pass actually removes a significant proportion of the THC, so leaving a much lower amount of THC in the bloodstream. Whereas when we look at bioavailability when we're smoking it, it can be as high as 50% of bioavailability that's in there right off the bat. And I think that when we think about all of the different substances that people are inhaling, and of course fentanyl has almost completely changed to smoking, it's because that bioavailability is very quick, the levels go very high, the effect on the brain is much more substantial. And so from a baby standpoint, what we're putting in their brain can be probably pretty significantly different when the bioavailability is much higher. Next slide. So causal effect, and a lot of the talk that I did previously on some of the adverse events of THC, especially when we look at schizophrenia, we look at anxiety, we look at all the different things that THC has been associated with, often we cannot really prove that causality. And the same thing really is going to hold true here, and for a lot of different reasons. When we think about cannabis, cannabis isn't just one thing. It's more than 500 different chemicals. And can we be sure that it's THC that's actually the determining problem to this whole situation? I think it's really difficult because many women underreport what they use, like by 60 to 70%. And I don't think that's unreasonable to think that when we get patients who use alcohol, often we're getting a number much lower from the patient than we're getting maybe from the family or the wife. And so people tend to underreport their use. And I think that's a pretty natural and normal thing to do. Plus, if we think about the effects of marijuana, how does their nutrition play into this? How does their smoking play into this? And how about all the other drugs that they may be using at the time? How are we going to show a causal effect of the marijuana when we have such a varied exposure that this baby has? So again, how? Well, sometimes the way we can control this is with animal studies, because we can kind of minimize those things that will make it more difficult to interpret. And so really animal studies are helpful, but again, do they always correlate completely with a human? And I think that's, again, something that we're going to have to wait to hear more information on. Next slide. So there have been some non-human primate studies, and they may have a little bit more to offer, especially because they have fetal development that's very similar to humans. They have a placenta that's not that different from our placentas, and it functions very similarly. The plasma disposition of THC and all of its metabolites seem to do pretty much the same thing in the primates that it does in humans. And so I do think this is a good way for people to do the research to kind of see. But clearly, the infants and the animals, as they grow and age, there's different things that would probably be more difficult to ascertain in a human as opposed to, or excuse me, in an animal as opposed to a human. The present problem is that when we look back at the studies that have been done, and these are years ago, most of them were done in the third trimester, focusing on really giving these animals daily use and watching fetal growth on ultrasound. But a lot of them also did it with IV dosing in these animals so that they could be very standardized. But clearly, this is not a way that humans are using THC, and do those doses and blood levels really correlate with what we would see in a human. Next slide. Stillbirth and miscarriage has been a big topic when it comes to marijuana, and actually there's reasonably good data on some of these things. Actually, when you look back at some of the human studies that were done early on, there was clearly associations with substance use in general and pregnancy loss. And again, can we look at that and say, well, this is definitely marijuana that's causing this, or is it the combination of the substances they're using? And a lot of the early studies really didn't show any big significant difference between stillbirth or early miscarriage with prenatal use, right? So if people stopped when they got pregnant, there tended to be very few problems. Next slide. But when we look at more recent studies, and the biggest one being the Stillbirth Collaborative Research Network, which tracks many, many patients. It's really the largest recent study that's out there at the time. And Coleman and Cowger et al., who were involved in this, their study looked at trying to separate out the marijuana, tobacco use, and pregnancy because, again, so many people are smoking marijuana, are also smoking tobacco use. And we have to know, are these things related in any way, or does it worsen with the combination? Next slide. And of course, we know that heavy tobacco smokers tend to have smaller babies. Their growth is certainly an issue. And so does it get worse with marijuana? They actually, this study actually looked at over 600 stillbirths from 5 clinical sites over just a couple of years. And they looked very carefully at the cord blood toxicology and also, looked at the nicotine that was in the blood samples, not just the marijuana. They did not use self-report. They wanted proof that patients had been using. They wanted some idea of the blood levels that they were seeing in this patient group. And they used these assays so that they didn't have to use the self-report. Now, they compared controls at the completion of the study, and they wanted to make sure that people understood that when they looked back, there was some difference in the controls as far as race and ethnicity and gestational age. But overall, they felt that they had come up with some pretty good thoughts on the stillbirth and marijuana and smoking correlations. Next slide. So what they found was this in a very simple way. Marijuana is significantly associated with stillbirth. If you are using in that first trimester, there is a significant chance of a stillbirth. The effect of marijuana probably is confounded by tobacco use, meaning that it's probably worse when people are using both, although that probably still needs to be worked out. Next slide. But the numbers were pretty significant. And when they looked at tobacco and marijuana use in an urban university population and compared tobacco alone, looking at any association in miscarriage, urine and hair samples were actually used in this study to confirm their substance use again, because they did not want self-report when they were looking at tobacco alone and marijuana alone. Next slide. So they did a very similar kind of thing as the other study. Next slide. But their results were more mixed. They didn't find exactly the same thing as the network found as to whether marijuana caused preterm labor or preterm birth. But a lot of the larger studies have shown an increase in preterm birth while others have not. And so the jury's really out on that. Obviously, there's going to need to be more research on that. But from a stillbirth standpoint, I think that's holding pretty strong, that the evidence for that is very strong. Next slide. And in fact, one of the biggest issues that they think may play into this is the fetal growth restriction that we see when we have patients smoking marijuana during their pregnancy. And there's been a number of studies that have really shown significant changes in birth weight that might range anywhere from 84 grams to 256 grams, depending on marijuana use, trimester, and probably the amounts that they were actually smoking. Now, there have been other studies that, again, showed no difference when they adjusted for other substances. And again, we see this in all the literature surrounding this particular topic, that people are finding often different outcomes. But one previous study actually looking at over 3,000 urban Black women showed heavy marijuana use alone was associated with reduction of birth weight, but again, not preterm labor. So again, we know that we're going to have weight issues. We know that we're going to have, if we're smoking in that first trimester, that there is going to be higher risk of stillbirth. Those things are, again, pretty solid. Next slide. So wrapping up this part, I think that we have to understand that cannabis is often used during pregnancy, and we need to be prepared to discuss its potential risks. I do think this is the same kind of problem that we see when providers are certifying people for marijuana, that they're not talking about the things that potentially can go wrong, like increasing anxiety, increasing risk of schizophrenia, decreased REM sleep, all these different things that can be a problem. And so we have to also have those conversations with pregnant women who continue to smoke and really make an effort to ask, not just to look at their screening where they may have said no because they don't want to self-report it or are concerned about child protection. A lot of the previous studies have been done during a time when, again, THC levels were low. And I think we're all going to be waiting for the ones that are using, really patients that are smoking more recent types of marijuana where our levels are so high. Again, the evidence is very good that cannabis is associated with stillbirth and miscarriage and clearly associated with birth of weight. And in fact, I have some stuff I'm going to talk about in a second where it also affects the size of the baby's head. Now, I'm not going to talk about the neurodevelopmental things. And again, that's going to be in a talk that's coming up in the next month or two. But I am going to talk just for a moment about some of the timing of when people smoke marijuana. There's just been, I actually last night looked at any of the studies that had come out since I made this talk just a couple, 2-3 months ago. There's been a couple pretty interesting articles coming out, and one of them about, does the timing matter? Does it make a difference when somebody smokes marijuana during their pregnancy? And they're not quantifying, it's just what part of their pregnancy did they use it? And does it negatively impact fetal growth at different times of our pregnancy? The study that was done actually by Dodge et al. Actually looked at about 300 patients, 100 of them using marijuana. And what they found was that if people smoked only during the first trimester, and imagine a lot of those patients are using it because they don't know they're pregnant, but some are just using it maybe because they're nauseated or they just don't want to stop. But those babies on average were 154 grams smaller than, and even if they stopped smoking after the first trimester. If they smoked through their entire gestation, they were a lot closer to 200 grams lighter than their cohorts. And no matter what happened, their heads were not as large. And in fact, they lost almost a centimeter of circumference of head, no matter when they smoked during their pregnancy, whether it was first trimester or the whole pregnancy. So the conclusion really is that, yeah, timing does matter. It's probably most detrimental to weight when people are continuously using. But again, as far as dosing, blood levels of the mom, all these things, there is no data to show if it's more, it's worse. And so I think that's something that's going to come out with time. Understand, again, they did not in any way, shape, or form try and separate these groups into heavy users and light users. I really think the bottom line, from a kind of a Minnesota perspective is, well, it's probably not good for your baby, right? That's the simple common sense answer. One of the things that I thought was interesting is that lately there have been people really looking into what is effective as far as treatment for pregnant women who are using marijuana. Is there interventions that we can do that might make a change, and what should those seem to have the best benefit? Because obviously we need an effective approach, and we need to decide, for the evaluation of this approach, we need to look at which one of these seems to have better outcomes as far as patients discontinuing their use. And actually, the review was done by Groff et al. And that was actually just this last year. And he looked at a sample size, of these studies that was anywhere from just 15 patients to almost 700 patients. And the interventions that all these different groups used varied from a brief counseling, CBT, motivational interviewing and CBT, and then some computer-driven stuff, and then some home visits where they would discuss the marijuana use with the patient. And basically, the conclusion of their review was very simple, is that interventions that seem to be best involve CBT and or motivational interviewing. So having a nice conversation with the patient, explaining the risks and benefits, explaining how the baby might be, and really doing some motivational interviewing surrounding that has probably thus far been what they felt most helpful without great data. In a way, it almost feels anecdotal. One of the things that we see when we see patients, that's the last little caveat, is treatment outcomes. What if we send people to treatment? How do these patients do who only are using marijuana? And in fact, they've done studies where they've taken patients who had not previously had a cannabis use disorder but developed one. And they actually took a huge group of people really from 2010 to 2019 and really looked closely at these patients, all with no prior treatment. And when these patients get to treatment, it's interesting that only 30% of them actually complete treatment. More often, they are being lost to treatment. The people that would stay at least 4 months, that was actually associated with more treatment. If they get to 4 months, they would more often tough it out and stay in treatment. If most of the people that were lost before that time. And what they found was that there were certain factors that really improved their treatment outcomes. And one of them was, number one, a referral from their provider. They'd had a discussion with their provider got them a referral to treatment. The justice system occasionally is involved, and we all understand that sometimes justice-involved individuals will be sent to treatment against their will. But as many of you know, often their outcomes are just as good as people who go voluntarily. And also, they found that these patients frequently had much better resilience and motivation as because of those particular ways they ended up in treatment. So I do think, at least at this point, treatment is always an option. 30% of the people, make it, and 60-some% of the patients actually end up dropping out. But I do think that it's certainly one of those things, the tools in our toolbox. So that is the end. We can take the slides down. I saw a few questions pop up. I don't know, Aaron, if you want to do those, or if people want to unmute. I'm happy to answer any of the questions about this.
Great talk, Kurt. Christine Bell did put in the chat, I found one study years ago that found an association between Mary Jane use and ADHD. Later, I used to talk to my patients about this because they were unfazed by preterm delivery.
Yeah, that's interesting. And it's that whole thing, what's the best predictor of one use disorder? It's having another one, right? So, people tend to use more and more. Was there a great review? I need to go to 1 p.m. No other real questions. Any other questions or thoughts? I think, to me, really the most interesting part of this is really some of the data coming out on the infants as they grow to young adults. And I do think that that's going to be interesting talk as far as how we evaluate these kids as they get older, some of the mental health issues that they have. and really from the get-go, and developmental issues. So really a great topic.
I have a question. You talked about CBT and motivational interviewing sort of being the frontline treatment options for this. If you did need to use medication of any kind, what would be your approach with that? And what's safe to use on a mama?
Yeah, and again, there's clearly nothing FDA approved there. I have never read anything that really had any significant data surrounding it as far as improvement. I don't know, Cole, have you seen anything?
I have not, no.
Yeah. I don't know, Cole, if you've seen they actually have I read this in ASAM, one of the ASAM journals, how they're developing as a, basically developing a medication that's basically going to block the receptors for marijuana, for THC, which I think is pretty interesting. And it was in studies last year. They think it's going to take a number of years to come out, but the main thing that they were thinking it was going to help was actually withdrawal, like that they would use it for withdrawal of people who are using heavy marijuana, because we've all seen those people. They're hard to get over that. Go ahead, Cole.
No, that's interesting. I haven't heard of that.
Yeah.
Yeah, I guess any blockade of all those CB1 receptors in the brain.
And that's apparently the goal. I saw it probably 6 or 8 months ago, and in your mind you're like, God, I hope that's out next month. But yeah, it won't be. It's going to be a while, and it'll probably be $1 billion. But yeah. Any other questions about pregnancy?
When you were doing reviews for this, did you see anything about like synthetics and data surrounding that and birth weight and head circumference?
Actually, no, I did not. I can't recall. They really were focused strictly on, most of the ones I pulled were on THC specifically. Yeah.
Interesting.
And I honestly think that we're in a position now where Colorado was 10 years ago. They're probably seeing these young kids now in school who have these difficulties. And again, they're talking about patients who are going to have early psychotic issues, potentially in their early teens. That's the suggestion at this point, and a lot of perception issues, a lot of difficulties. So I think we're going to be seeing this now because of legalization. We're going to be seeing this 10 years from now. It's going to be the pediatric people are going to be dealing with it. Pediatrics.
It'll be interesting to see if there's any other physical presentations like there is with fetal alcohol syndrome or anything like that come about from this. Ruth did put in the chat, any way to differentiate between nausea related to pregnancy and nausea and vomiting from the marijuana use?
And I don't know if somebody else to comment on this, but I'll tell you what, convincing somebody that the marijuana is making them nauseated and puke is maybe one of the hardest things in medicine, right? They think two things. They think, number one, three things. It helps me sleep, which is probably not true. It helps my anxiety, which is more often than not true. And they think it actually helps my nausea, but no, it doesn't. And so that's really tough. I think if they were to quit for 4 or 5 days and their nausea went away, it's clearly not gestational, right? It's clearly not related to the pregnancy. I have had so many of those patients over the years, and getting them to believe that it's the weed is pretty tough. I mean, I got a guy I'm taking care of now who's now 40, and I first took care of him when he was 14, vomiting in my ER. And I have had the discussion with him for 25 years. So yeah, he keeps showing up. It's always something else. So the increase in ADHD was seen in the child of the parent who continued to use marijuana during pregnancy. Yeah. Yeah, and that's, again, that's going to be a part of that next talk. And there are a lot of things from a mental health standpoint that are going to pop up in kids whose parents smoked weed, especially continuous and high dose. I think we're going to see some real troubles. I think one of the hardest parts of this is that when we think about fetal alcohol syndrome, at least we can look at a baby and have a feeling that we should be looking for some of the developmental issues. I think this is going to be different, where often I don't think there's going to be stigmata, where this kid's going to be having troubles and we're going to have a hard time linking it to it, right? Unless you go back to the mom and really get a history on the pregnancy. So it's going to be a little different. So, all right.
Other questions before we wrap up?
All right. Well, I hope that gave everybody do you think the drop in treatment programs? Oh, what did it say?
Do you think early dropout in treatment programs is that cannabis users don't feel like they have as big of a problem as other drug users?
I think that's some of it, but I don't know. And again, Cole, if you want to weigh in, or anybody else that does treatment, I think often it's this prolonged withdrawal. They just don't feel right. I'm dealing with a guy now who is using 3 different substances, and he's a month out, and he was a heavy weed smoker, and I'm convinced it's the weed that he's just dying to just take a hit to make it go away, right? So I think that's some of it. All right, everybody, I'm going to give you 10 minutes back of your day. So next week, we have no echo. The week after that, we're going to be talking about PrEP, as I recall. Or is it suicide?
Zero suicide is July 10th.
Yep, so that'll be a good talk. All right, everybody, thanks so much. Have a good holiday.